Hello everyone, good night. It's 9 p.m. Wednesday Cairo night and our usual appointment and our usual timing for having our Wednesday night lectures. Greetings all the way from Bahrain to everyone following us from Egypt and from the whole world. Uh, last night wasn't the best night for Egyptians, but I hope tonight would be better than yesterday. Congratulations for the great work that the Egyptian team has done last night. And tonight we are continuing our ovarian cancer module for this year course of OCMO, EGOS, PARSCO, Bahrain Gynecology course. And it's a pleasure always to have Dr. Amany Hassan, Assistant Professor of Pathology, and she is the pathological cornerstone of our team, of our Egyptian team for gynecology, and really one of the international figures in gynecology pathology. Amani is going to present pathology of ovarian cancer over 2 weeks, as I have understood from Dr. Khalid Gaballa. And I have the pleasure to present here today on behalf of OCMO team and on behalf of Dr. Khalid Gaballa, who has special circumstances tonight. So, Amani, the floor is yours. For everyone, you can put your questions in the Q&A box or in the chat box, and we will open the questions for discussions after Amani finishes her lecture. Go, Amani.
Hello everyone. Happy to join you today. We'll talk today about pathology of ovarian cancer. This lecture will be longer than the next lecture, and the next week will be a small lecture. I will try to focus on the things that are important for clinicians, not the histopathological specific features. So here is the WHO 2020 classification of ovarian epithelial carcinoma, and here are the main five common subtypes: high grade serous, low grade serous, mucinous, endometrioid, and the clear cell carcinoma. The new WHO 2026 will be published soon this year. Regarding the frequency, the high-grade serous carcinoma is the most frequent subtype, followed by clear cell and endometrioid carcinoma, while the low-grade serous carcinoma and the mucinous carcinoma are the least common subtypes. So why do we need to accurately classify ovarian carcinoma? Because they differ in their platinum sensitivity, may differ in other forms of treatment, as we are now in the era of personalized or precision medicine. Genetic testing and cancer prevention may differ between subtypes, like in high-grade serous carcinoma, BRCA1 and 2, and hereditary breast ovarian cancer syndrome is important. In non-serous carcinomas like clear cell and endometrioid, we look for Lynch syndrome. So we'll start by serous tumor. There are a dualistic model for pathogenesis of serous tumor, two pathways. The first pathway, harbor KRAS and PRAF mutation, and this pathway shows a spectrum of lesions from benign to serous borderline tumor, micropapillary variant, and low-grade serous carcinoma. The other pathway, characterized by p53 mutation, BRCA1 and 2, loss of function and chromosomal instability, and this is the pathway for high-grade serous carcinoma. And the precursor for this is tubal intraepithelial carcinoma. So serous tumors have benign, borderline, and malignant categories. The benign called cystadenoma or adenofibroma, the borderline serous tumor, and the micropapillary/cribriform variant. The malignant is the low-grade and high-grade serous carcinomas. So here is the serous cystadenoma. It's just a cyst with thin wall, smooth outer and inner surface, no solid component or papillary excrescences, and lined by planned serous epithelium. It can be either maybe solid component and firm papillary structures inside it. We call it serous cystadenofibroma. But these papillae show no epithelial proliferation. It's just large fibromatous papillae. So this is a serous cystadenofibroma, and this is also a benign category. The serous borderline tumor is considered to be a precursor for low-grade serous carcinoma. This tumor shows a greater epithelial proliferation than serous cystadenoma with mild to moderate degree of atypia, but there is no invasive carcinoma. It has wide age range, the mean about 42, not associated with BRCA mutation or TP53 mutation, but have KRAS or PRAF mutations. The serous borderline tumor, about 70% of cases confined to the ovary at the time of the diagnosis, while others may have extra ovarian disease. It's bilateral in about 1/3 of cases and has only 3 to 10% risk of recurrence and only 4% risk of malignant transformation. Here's the classic serous borderline tumor. This is an ovarian cyst bisected, show cystic lesion, and this papillary structure, exuberant papillary structures arising into the lumen. This is a classic appearance of serous borderline tumor. And in this case, here is the ovary, and this case shows surface involvement of the ovary by these papillary structures. So this is a serous borderline tumor with surface involvement. Under the microscope, it looks at these papillary structures, looks like papillae with hierarchical branching, so larger papillae giving its way to smaller papillae, and like a tree-like pattern. Here is the papillae of borderline tumor, and the degree of atypia is mild to moderate. No marked atypia is allowed in serous borderline tumor. So when we have this hierarchical papillary tufting in more than 10% of the tumor and or on the surface, this is a serous borderline tumor. If only this proliferation is about 10% of the tumor and is intracystic, we may call it serous cystadenoma with focal proliferation. This is equivalent to benign. So what is the features that thought to be of prognostic significance in serous borderline tumor? It's grouped in SMILE, stage, surface involvement, micropapillary cribriform variant, microinvasion, implant, and lymph node involvement. So first, the surface involvement. Surface involvement of serous borderline tumor, like in this picture, is significantly associated with the presence of implant. So these cases more likely to have implant, more likely to have positive peritoneal washing, as these papillae on the surface will yield some cells in the peritoneal fluid. In absence of a demonstrable peritoneal implant, this is called borderline tumor stage 1C and have a good prognosis. The micropapillary cribriform variant, here is the shape of the micropapillary variant. We always say it has the shape of Medusa head appearance because it has very long papillary structures. And here is the cribriform variant to show fusion of these papillae giving cribriform pattern. It's equivalent, both are the same entity, micropapillary / cribriform variant. We may see micropapillae, we may see cribriform, we may see both. So to say this is a micropapillary cribriform variant, they must measure this area, must measure at least 5 millimeter to say this. A very small, less than 5 millimeter, it's just a serous borderline with focal micropapillary features, and this has no significance. The micropapillary variant of serous borderline tumor is more likely to be bilateral, more likely to have surface involvement and have higher stage disease, so more likely to have implants, and have worse prognosis compared to the serous borderline tumor with increased risk of recurrence. However, the adverse features of micropapillary borderline tumor thought in most studies disease are more likely due to the presence of surface involvement and higher stage disease rather than the micropapillary borderline tumor itself. So in the past years, we may see in the older literature, this micropapillary variant was said to be non-invasive low-grade serous carcinoma, but now it's called micropapillary variant because it has no significant adverse effect, independent adverse effect on survival. Its prognosis worse than borderline tumor due to its association with surface involvement and higher stage disease. So it's managed similar to the typical borderline tumor, but need thorough sampling by the pathologist to rule out invasive carcinoma. Regarding microinvasion, this is a serous borderline tumor with microinvasion. Microinvasion means that there's a small clusters of eosinophilic cells. These are senescent cells measure less than 5 millimeter. When we find this in a serous borderline tumor, we call it serous borderline tumor with microinvasion. Most studies showed no adverse effect on prognosis, and the management wouldn't differ from a serous borderline, so no need to panic when we see there is a microinvasion. Long-term follow-up may be recommended, and also thorough sampling is important to exclude that there is something more like carcinoma. However, this is different from microinvasive carcinoma. Microinvasive carcinoma, this means that we have an area that's cytologically and architecturally similar to carcinoma, but less than 5 millimeter. And this is rare, and the clinical significance of it is unknown, and need thorough sampling to exclude frank low-grade serous carcinoma. Because this area is so debatable and so confusing, in the recent WHO classification that will be published soon this year, the WHO 2026, the term microinvasion and microinvasive carcinoma is removed at all, and the serous borderline tumor with microinvasion is just called a serous borderline tumor because this has no effect on prognosis. And the serous borderline tumor with microinvasive carcinoma are called a low-grade serous carcinoma with specification that these foci are small and measure كذا milli in background of serous borderline tumor. So this is we will see this practice soon when the book will be published. Regarding peritoneal involvement, it occurs in about 1/3 of cases. Most cases, about 86% of this peritoneal involvement is non-invasive implant. Non-invasive implant means that they are present on the peritoneal surface, no invasion and destruction of the omental stroma, and can be classified into something called epithelial or desmoplastic implant. It's adverse prognostic factor, but not as bad as invasive implant, and time to adverse outcome is long. Invasive implant are now called the low-grade serous carcinoma. So we can see a serous borderline in the ovary with invasive low-grade serous carcinoma in the omentum. The behavior and prognosis are equal to low-grade serous carcinoma. And this has the destructive invasion and distortion of the normal omental tissue, and this is only for 14% of the advanced cases. So it's rare. Here is the non-invasive implant, and here is the invasive implant with destruction of the omental fat by tumor tissue. Regarding lymph node involvement, so lymph node is not routinely removed in serous borderline tumor, but just to be aware that if there is some lymph node removed of serous borderline tumor and have these small papillary clusters in the subcapsular sinuses, this is okay in serous borderline tumor. This can occur more common in cases with surface involvement and implant, and is not independent predictor for disease-free survival or overall survival, but we see it's we report it as N1 serous borderline tumor, but this is not equivalent to metastatic carcinoma. Unlike but some cases of serous borderline tumor can show destructive invasive low-grade serous carcinoma in the lymph node. This will be called as carcinoma. So lymph node involvement is different from involvement of the lymph node by low-grade serous carcinoma. So here is the serous borderline, and here is the low-grade serous carcinoma in the lymph node. The peritoneal fluid cytology. So the serous borderline tumor can have positive peritoneal fluid cytology. This is because we have this tumor has papillary structures. These papillae are exfoliating cells, so these cells can fall in the peritoneal fluid, and we can see a positive cytology. When we see this cytology from the serous borderline tumor, by the morphology alone, we cannot say that this is a serous borderline tumor or low-grade serous carcinoma in the cytology, as we cannot see the invasion. So in these cases, we report it as involved by serous neoplasm or low-grade serous neoplasm, and the definitive classification defer to surgical specimen. And this is one of the important things that make biopsy. The tissue biopsy is always better than cytology in diagnosis of advanced ovarian malignancy. So the low-grade serous neoplasm can have multifocality. So I can have serous borderline tumor in the ovary with implant in the peritoneum and lymph node involvement, and this is a serous borderline tumor. Or I can have a serous borderline tumor in the ovary with low-grade serous carcinoma in the peritoneum or low-grade serous carcinoma in the lymph node. Regarding the tube ovarian serous carcinoma, there are two distinct types, low and high grade. These are two distinct types. There are not two grades of the same neoplasm. They are different in neoplasm with different underlying pathogenesis, molecular events, behavior, and prognosis. The high grade serous carcinoma is much more common than low grade serous carcinoma, and no place for diagnosis of well, moderate, or poorly differentiated serous carcinoma. This is not accepted. Very rare to get admixture or areas of transformation of low grade to high grade or areas of heterogeneity, but this cases is rare and need molecular analysis to be sure of the exact type. So low-grade serous carcinoma is uncommon, about 5% of all ovarian carcinoma. The age range from 12 to 80 years, can have advanced stage at presentation, can occur de novo or associated with serous borderline tumor. So here is example of our cases, low-grade serous carcinoma. So we'll have this tumor has predominantly solid architecture as we have invasion. So the papillae are minute papillae, but there is a major significant solid component. This solid component show invasion by these micropapillary structures surrounded by clear spaces with extensive calcification, destroying the underlying stroma. The degree of atypia is mild to moderate, and the mitotic activity is low, less than 12 per 10 high power field. So this is a low-grade serous carcinoma. This is the MD Anderson system for classifying low-grade and high-grade serous carcinoma based on the atypia and the mitotic activity. So the high-grade show high atypia with more than 12 per 10 high power field, and the low-grade show commonly mild to moderate atypia with a low mitotic count less than 12 per 10 high power fields. So markers of low-grade serous carcinoma, it will be PAX8 and CK7 positive. WT1 is positive, is a good marker for serous carcinoma, the low-grade and high-grade. The B16 will be patchy positive. Patchy positive means it's not abnormal. B53 is wild type always. ER is positive in more than 90% of tumor, and PR is also usually positive. The recurrence in low-grade serous carcinoma, more than 80% of cases will recur, but the 5 overall survival is 70%. In cases with advanced disease, the survival is time dependent, so less than 30% survival at 10 years. The prognostic factors in low-grade serous carcinoma, the age if younger than 35 years, the advanced stage, if there is residual disease after operation, if there is its MAP kinase mutated tumor, have better prognosis. So genetics of low-grade serous carcinoma tend to have abnormalities in MAP kinase pathway, KRAS or BRAF mutation. There is no BRCA or TP53 mutation. The low-grade serous carcinoma, generally it differs from high-grade serous carcinoma at the management level, as the surgery is more likely in low-grade serous carcinoma. No great response to chemotherapy. They may benefit from targeted therapy as MAP kinase pathway and MEK inhibitors. Hormonal therapies may be an option, and it's not associated with BRCA mutation. And here's a table for difference between low-grade and high-grade serous carcinoma. High-grade is more sensitive to platinum and PARP inhibitors than the low-grade serous carcinoma. High-grade serous carcinoma is about 70% of all ovarian cancer. 20% is early stage, stage 1 and 2, and 80% of cases, unfortunately, is a advanced stage, stage 3 to 4. Here is the gross appearance, show this solid architecture. We may have some papillary structures. They have multiple patterns under the microscope. We may see micropapillary, macropapillary, glandular, solid structures, but all these show high degree of nuclear atypia and high mitotic activity, more than 12 per 10 high power field. There is something called the SIT pattern of serous carcinoma, called the solid pseudo-endometrioid transitional pattern. So you may see this in your pathology reports. What's the significance of this pattern? This pattern means that this tumor tended to occur more at younger age, tended to have more BRCA mutation or HRD, more platinum sensitive, and more response to PARP inhibitors. So it's just a pattern we see under the microscope. But we cannot reliably pick out the BRCA-associated high-grade serous carcinoma based on morphology. Markers in high-grade serous carcinoma, like low-grade serous carcinoma, the PAX8 and CK7 usually positive, WT1 positive, B53, unlike low-grade serous carcinoma, will show mutant pattern of expression. The B16 in 2/3 of high-grade serous carcinoma will show block type positivity, and the ER tended to be positive in 70 to 80%. WT1 may help in differential of high-grade serous carcinoma of adnexal origin versus uterine origin, but sometimes give unclear results when it's focal, and sometimes uterine serous carcinoma tended to show some WT1 expression. So it's only helpful when it's negative. If it's negative, this is an endometrial serous carcinoma. It's positive. We may have a tube ovarian serous carcinoma, but there is exceptions. So in any serous carcinoma, I would see the PAX8 positive, WT1 and ER positive. The low-grade serous carcinoma will show wild-type pattern of expression of P53, and high-grade serous carcinoma will show mutant pattern of expression of P53. So a P53 is recommended to be reported as wild type or mutant pattern. This is preferred for P53 reporting in gynae pathology. The P53 positive or negative is meaningless in gynae pathology. This is not acceptable in gynae pathology to say it's positive or negative. We must say it's wild type or mutant type. Why? Because the wild type pattern like this in low-grade serous carcinoma, this is a case of low-grade serous carcinoma, show some expression of P53 in weak focal nuclei. A high-grade serous carcinoma show mutant pattern of expression that can have multiple shapes. Here is one of them, the strong diffuse expression, more than 80% of the nuclei. Here is the complete absence of expression with positive control and negative expression. This is called the null phenotype of P53. So this is a mutant, but there is no nuclear staining is present. So this is why we must say it's mutant or wild type. If we say it's positive or negative, we will not know it's mutant or not. And here is a rare pattern called cytoplasmic staining of P53. This is very rare. The ICCR dataset and the recommendation of the ESMO ESP recommendation in cases of high-grade serous carcinoma, if neoadjuvant chemotherapy is administered, we must have a pre-treatment biopsy is recommended for tumor typing. If not possible, then the diagnosis of malignancy can be made on cytological examination of the acidic fluid with IHC on cell block preparation, but this is only if it's not possible to take a biopsy, because there will be a limitation to interpretation of IHC on the cell blocks. Minimum panel to be used, the PAX8, WT1, ER, and P53. So why it's important to take a biopsy? Because the preoperative chemotherapy may significantly alter the microscopic appearance of the tumor and result in difficulties in the tumor typing. So if you have a biopsy of the tumor, this will facilitate accurate typing before chemotherapy. The patient may never be operated on, so this may be the only biopsy he had. The patient may have minimal or no residual tumor, so we see some cases was diagnosed as serous carcinoma based on cytology, and then the tumor disappeared by chemotherapy, and they tried to do the BRCA testing on the cell block from the cytology, and the cellularity was low in the cytology and couldn't do the BRCA testing. So this is important to have a preoperative tumor biopsy before chemotherapy. The ESMO ESP recommendation say that the distinction between the low-grade and high-grade serous carcinoma based on combination of morphology and P53 IHC. In diagnostically challenging cases, we may refer it to specialist or molecular testing. In cases with the morphology, if I have a case with morphology of low-grade serous carcinoma, but with P53 protein overexpression or mutation, it's recommended to be classified as high-grade serous carcinoma. So regarding the genetics, the TP53 mutation is characteristic of high-grade serous carcinoma. 50% of these will have HRD, homologous recombination deficiency, either germline or somatic. BRCA1 and the BRCA2 germline and somatic mutation is present in almost 25% of cases, and also these cases characterized by chromosomal instability. So a few slides about homologous recombination. So we tend to test the high-grade serous carcinoma, and this will be discussed extensively in the lecture of genetics and high-grade serous carcinoma. For HRD and the BRCA mutation, HRD contain more genes than those in the BRCA1 and the BRCA2. So a few slides about the homologous recombination repair. We have two repair systems for the DNA damage, the single-stranded repair and the double-stranded repair. So the single-stranded repair, one of it called the base excision repair. The double-stranded repair either homologous recombination or non-homologous recombination. So this slide is of courtesy to Dr. Lauren Schwartz. She allowed me to use her slides. So here is the DNA repair pathways. Here is the DNA, the double strands of the DNA. If there is double-stranded PREC, the homologous recombination system that repair the double-stranded breaks will fix it, and the DNA return to norm. If there is alternation in the homologous recombination pathway and there is a double-stranded break, this will increase susceptibility to carcinogenesis. What about PARP enzymes? What they do? So PARP enzymes have key role in base excision repair. Base excision repair is a repair to single-stranded issue. So when we have a DNA with a single-stranded break, the PARP enzymes assist in their repair and get fixed. So how do PARP inhibitors work? When there is a single-stranded break, when we block the PARP enzymes, so the single-stranded break will not be fixed, and this is a single-stranded breaks converted to double-stranded breaks. So we have tons of DNA damage, as we have a lot of double-stranded DNA breaks. If the homologous recombination system is impacted, the damaged cells may survive. If overwhelmed, as in high grade, in 50% of cases of high-grade serous carcinoma, this will lead to cell death, as there will be tons of DNA damage, and this causes lethality to the cell, so the cell die. So this is why we use PARP inhibitors in high-grade serous carcinoma, and why they have significance in the cases with HRD deficiency, because in these cases, the PARP inhibitors block the single-stranded breaks, and the single-stranded breaks converted to double-stranded breaks, and the double-stranded breaks will not be corrected as there is homologous recombination deficiency, so this leads to cell death. So the PARP inhibitors work best when used in HR deficient cells. Regarding chemotherapy response score, unlike other organ systems, there is very little published literature on this. There is a 3-tier chemotherapy response score system that's reproducible and easy to apply. It's only applied to tube ovarian high-grade serous carcinoma. This is not applied to endometrioid, clear cell, or any other types. We apply it on the omentum because this is the most prognostic, to apply it on the omentum in the block with the least response to chemotherapy. And there is significant difference of prognosis between chemotherapy score 1 and 2 and compared to 3. Patients with chemotherapy response 3 have significantly improved the progression-free survival and overall survival, and this is a pathological marker of platinum sensitivity. And here is a meta-analysis and systemic review on pathological chemotherapy response score that found its prognostic in tube ovarian high-grade serous carcinoma. And here is the score, score 1, 2, and 3. 3 is a complete or near complete response, means that there is mainly regression-associated fibroinflammatory changes with minimal or few irregularly scattered individual tumor cells or groups. Regarding the origin of high-grade serous carcinoma, traditionally it was thought to arise from the ovarian surface mesothelium. Studies showed that the majority of ovarian high-grade serous carcinoma arise from the tubal epithelium of the fimbrial end of the fallopian tube, not from the surface of the ovary. From a lesion called the STEC. STEC means serous tubal intraepithelial carcinoma. So this is the precursor for high-grade serous carcinoma. However, some cases, about 15 to 30% of high-grade serous carcinoma, no lesion identified in the fallopian tube despite extensive sampling using the CFAM protocol. We'll know now what is the CFAM protocol. Here is the CFAM protocol. The CFAM protocol means sectioning and extensively examining the fimbriated end of the fallopian tube. Means that we cut the fimbriated end longitudinal section and submit it entirely with circular sections from the fallopian tube. This makes us examine the fallopian tube extensively. All parts of the fallopian tube epithelium is clear, so we can see if there is a STEC or anything, small lesions in the fallopian tube. And assigning the primary site of origin of high-grade serous carcinoma after the CFAM protocol, we can say the high-grade serous carcinoma is ovarian in origin or primary fallopian tube in origin or primary peritoneal carcinoma in origin. So if there is anything in the tube, it's STEC, tubal mucosa involvement, carcinoma, there is tubal mass, the tube not identified or fused with the ovaries, this is considered a primary fallopian tube carcinoma. If no STEC, called the primary ovarian carcinoma. If there is, we only say primary peritoneal carcinoma if there is no tumor in the ovary, in the fallopian tube, after extensive sampling by the CFAM protocol and after microscopic examination. So if we examine the fallopian tube and the ovaries by the CFAM protocol, and we see nothing at all, and the lesion is only in the peritoneum, in this case we call it primary peritoneal carcinoma. The mucinous tumors, we'll go now to the mucinous tumors. Also, we have a benign category, borderline and malignant, and the benign primary mucinous ovarian carcinomas have wide age range, may occur in young female, and the mucinous carcinoma is the most common epithelial malignancy in young female. It's usually very large and unilateral. Generally, all mucinous ovarian tumor usually very large and unilateral, and usually stage 1 with a smooth outer capsule that may be ruptured. This is important information to know about mucinous ovarian tumor, that these tumors are usually stage 1. So when we see any mucinous tumor that's not a stage 1, we have to rethink if this sure a primary ovarian tumor or not, because generally the general feature of mucinous ovarian carcinoma, it's large, unilateral, and stage 1. Often multiloculated with or without the solid areas, often have mildly elevated CA 125, may have increased serum CA 99 CA. We don't use ever the term implant with mucinous borderline tumor. The mucinous borderline tumor don't have implants. Implant is for serous tumor and seromucinous tumors only. So here is the mucinous cystadenoma. It's the cyst with a smooth outer surface and inner surface, and the multilocular. This is usually unilateral and large, and this is a benign but may recur after rupture or spillage. Here's the classic mucinous cystadenoma, mucinous epithelium with a small basal nuclei, no stratification or epithelial proliferation. The mucinous cystadenoma can be associated with Brenner tumor or dermoid cyst. Mucinous borderline tumor is unilateral, more than 90% of cases. So if we have something called the mucinous borderline tumor, and we have disease in the omentum and the ovaries and the other organs, so this is not a mucinous borderline tumor or primary ovarian mucinous borderline tumor. This is against the concept of mucinous borderline tumor. The mean size about 17 to 22 cases, localized to the ovary, may be associated also with Brenner tumor or dermoid cyst. Usually is a multilocular cystic neoplasm and may contain solid foci. In these mucinous borderline tumor, the pathologist need to do extensive sampling in these tumors. So we increase the sampling in these tumors to capture any small foci of invasive carcinoma because they can be very heterogeneous. So here is the example, the mucinous cystadenoma here, and here is area passing to a mucinous borderline tumor. So in areas of the lesion, there is a cystadenoma, but in other areas, there is a proliferation, villus and papillary proliferation and stratification. This proliferation must be at least 10% of the tumor to call it mucinous borderline tumor. If less than 10%, we call it a mucinous cystadenoma with focal proliferation. The mucinous borderline tumor tend to have generally a mild to moderate degree of cytological atypia and no stromal invasion. If I have a case of a mucinous borderline tumor with the epithelial lining show marked atypia but no stromal invasion, we called it mucinous borderline tumor with intraepithelial carcinoma. I'm focusing on this because we see this in the pathology reports, these terms, and we don't know what's the significance of these. So mucinous borderline tumor with intraepithelial carcinoma have excellent prognosis. Very rare cases may recur. So this is not equivalent to carcinoma. About microinvasion, we have a mucinous borderline with microinvasion if less than 5 millimeter, and we have a mucinous borderline with microinvasive carcinoma less than 5 millimeter also. But the difference in the appearance, the mucinous borderline with microinvasion, these foci have no severe atypia. The atypia is similar to the mucinous borderline tumor. However, these with microinvasive carcinoma have marked atypia and irregular pattern of invasion with desmoplastic reaction. The behavior is different between both. So the micropapillary border, the mucinous borderline tumor with microinvasion they have no clinical significance. It's just like a mucinous borderline tumor. However, the mucinous borderline tumor with microinvasive carcinoma, it's rare and the prognostic significance is not clear, but some cases have potential for aggressive behavior. We also may see rarely in the mucinous tumor something called the neural nodules in the wall. Neural nodules mean there is a nodule in the wall, can be benign nodule or malignant nodule. Benign nodule, we call it something like sarcoma-like nodule. Sarcoma-like nodule, it's nodule that present in the wall, contain multinucleated giant cells and spindle cells, but they are benign. And there is a malignant nodule, mural nodule in the wall of the mucinous tumors, maybe anaplastic carcinoma or sarcomatous nodule. So the sarcoma-like nodule is benign. The malignant nodule, anaplastic carcinoma or sarcomatous nodules, this is malignant and tend to have poor prognosis. The outcome may be more favorable if it's stage 1A. The behavior of the mucinous borderline tumor. The mucinous borderline tumor is almost always unilateral and the stage 1 at presentation and has excellent prognosis. Although they may recur following cystectomy or incomplete removal or occasionally after spillage. There has been some debate about mucinous borderline tumor, whether it's a borderline tumor or benign, since it has an excellent behavior. However, it's kept in the mucinous borderline category because there is a risk of recurrence following incomplete removal or spillage, and there is also a risk of undersampling of carcinoma in the borderline tumor, because these tumors are tended to be very large. Even if we sampled it very well, there will be a very small risk that small carcinoma may be missed. So they keep it in the borderline category for this. In a population-based study, about 4 to 10% the risk of malignant progression following diagnosis of mucinous borderline tumor. So it's a very low risk, and this risk probably is explained by undersampling of carcinoma component at time of initial evaluation. The mucinous carcinoma, there are two types of carcinomas, expansile and infiltrate. The expansile, this is the more common. Generally, the mucinous carcinomas of the ovary more common to be expansile in pattern, and this is more common to have. This tend to have good prognosis, to have excellent prognosis. These purely expansile tumors have excellent prognosis, close to borderline tumor. However, the presence of infiltrative pattern of invasion, this is less common and have worse prognosis. And in any mucinous carcinoma, when there's infiltrative pattern, we must exclude metastasis, especially bilateral, because the infiltrative pattern is less common to be seen. The expansile is the more common. The mucinous carcinoma markers, it's tended to be CK7 and CK20 positive, but CK7 is more predominant than CK20. Unlike other ovarian carcinoma, it's completely negative, generally completely negative for ER and PR. PAX8 is tended to be negative, unlike other ovarian carcinoma, only show focal weak expression. The B53 may be mutated. It's negative for WT1 and the NAPSIN-A. There is a group of mucinous tumors that arise in association with teratoma, lower GI T phenotype, so may have the positivity for CK20 and CDX2 and negative CK7, but this is a very rare group. It's also negative for SADB2. This help in differential diagnosis with lower GI malignancy, and HER2 amplification found in some cases of mucinous borderline tumor and mucinous carcinomas. The grading of ovarian mucinous carcinoma is controversial, so there is no well-validated grading system. It's not a core item in all data set, but it's some recommendations for management may be dependent on the grade. So we may use a grading system called a Silverberg grading system. It's acceptable to be used for ovarian mucinous carcinoma, and it always recommended to say the mucinous carcinoma, it's expansile or infiltrative, and if both component present, the percentage of each component, it's focal, the infiltrative component is focal less than 10 or diffuse more than 10%, because this has a prognostic significance. There's a growth-based pattern grading system. This depends on the expansile and the infiltrative pattern. So this is a grading system based on this and found it to be prognostic in mucinous carcinoma, but still not a core item to be reported, but we may use it. There's an important topic we have to talk about when we're talking about mucinous tumor, it's a pseudomyxoma peritoneum. So the mucinous tumors in the ovary don't cause pseudomyxoma peritoneum. So if we have any case of pseudomyxoma peritonei, this case may be of appendiceal in most cases, or very rare, maybe of other intestinal origin, other areas in the GI. So we don't see pseudomyxoma in mucinous, primary mucinous ovarian tumors. If we have a pseudomyxoma, this tumor is not primary ovarian mucinous tumor, because this is a common pitfall. We saw sometimes reports say that this is a mucinous borderline tumor and say that the omentum show a mucinous deposits and there is mucin everywhere. So this is not compatible with this being ovarian mucinous borderline tumor. As we said, this is mostly unilateral and stage 1 at presentation. So if we see any mucinous material, any mucinous deposits outside the ovary with accumulation of mucin, like the picture of pseudomyxoma peritonei, this is most likely of appendiceal origin. The only situation to be arisen from the ovary, if the mucinous tumor in the ovary is on top of teratoma, and this is a very rare scenario. I saw only one case of teratoma associated lamin, low-grade mucinous neoplasm. So this is a very rare scenario. So this is very, very important because it's a common pitfall. When you see this, the pathology reports say that this is a primary ovarian tumor and there is pseudoamyxoma, this report should be revised. This can't be true. Endometriosis related tumor, we have the endometrioid carcinoma, the clear cell carcinoma, the seromucinous borderline tumor, and the mesonephric-like adenocarcinoma. The endometrioid carcinoma and the clear cell are the most common to have arisen in endometriosis, and this we'll talk about. The seromucinous borderline tumor, it's rare, so we'll not spend much time on it, but it can have implant-like serous borderline tumor. The mesonephric-like adenocarcinoma is also a rare entity, so I'm not speaking about it, but I want you to know that this is an aggressive tumor that arises on top of endometriosis and very rare and have tendency for lung metastasis and have a specific immunoprofile for it. The endometrioid tumor also classified as benign, borderline, and malignant. But we usually see the malignant counterpart, the borderline and the benign less common. The endometrioid carcinoma of the ovary is about 10 to 15% of ovarian carcinoma, up to 90% associated with endometriosis, can be in the same ovary or in the pelvis. The precursor lesion for this atypical endometriosis and borderline endometrioid tumor. Usually, we have to know that endometrioid carcinoma is usually unilateral and large, and most are stage 1 or 2. If the ovarian tumor is adherent to the surrounding pelvic structure, it may be due to endometriotic lesion, not to tumor infiltration. So these tumors, because they're surrounded by endometriosis, there may be sticky to the background, and there is a lot of adhesions that may give impression to the surgeon that this is advanced tumor, but all of these lesions are endometriosis. Tend to have expansile pattern of invasion, more common, extensive gland diffusion, large areas of cribriforming and papillary structures, less often to have destructive stromal invasion. Grading is the same as uterine tumor. Most are low grade. So we don't see high grade endometrioid carcinoma in the ovary, very common. Unlike in the endometrium, we may see high grade endometrioid carcinoma, but in the ovary is uncommon or rare. Most the endometrioid carcinoma in the ovary is low grade. There is the classic appearance of endometrioid carcinoma, the fused gland-forming cribriform structures with areas of squamous differentiation. So the endometrioid carcinoma will be positive for CK7, BAX8, like other ovarian carcinomas, will be negative for CK20. The ER will be diffusely positive. CDX2 may be positive in squamous modules. The WT1 is negative or focal weak. May show mismatch repair deficiency, may show loss of P10. The molecular classification of endometrioid carcinoma is also can be applied on ovarian endometrioid carcinoma with the 4 molecular subtypes represented. The hypermutated subtype with mismatch deficiency in about 13% of cases. The ultramutated poly type 15%, the P53 mutated in 9 to 13%, and non-specific molecular profile is the most common, about 69 to 73%. Now we'll go to an issue that we encounter in our practice, the synchronous ovarian and endometrial endometrioid carcinoma. This scenario will occur in about 15 to 20% of cases. We will see endometrioid carcinoma in the endometrium and endometrioid carcinoma in the ovary. So these tumors have a lot of studies done on them along decades. Recent studies, large colonality studies done on them, when we study the molecular signature of these tumors, found that most of these tumors are clonally related. What the meaning of clonally related? The meaning of clonally related that they are metastatic from the endometrium to the ovary. Even if the tumor in the endometrium is superficial, even if there is no lymphovascular invasion, even if it's very early unilateral ovarian involvement, the clonality study proved that these tumors are metastatic from the endometrium to the ovary. And there are some theories for how they spread to the ovaries. But at the behavior level, there are two groups. Group that have good prognosis and behave like independent primaries, and the group that will not have this good prognosis and behave more like metastatic. So we classify it now based on the behavior, not on the pathogenesis. So this is important to understand. As we may see some cases, the clinician say why we say this case is metastatic from the endometrium to the ovary, because the tumor in the ovary is ruptured. There is no intact capsule. How it's a metastatic from the endometrium to the ovary in this situation? Because we apply, all these cases are metastatic. We apply now risk stratifications based on the behavior of these tumors. How? In the WHO 2020, they proposed a criteria for tumors that will behave are like independent primary. So these tumors, if both are low-grade endometrioid, if less than 50% myometrial invasion, if there is no involvement of any other site, if there is no extensive lymphovascular space invasion at any location, in these scenarios, we will say that these tumors will behave like independent primary. And ignore that they are at the pathogenesis, they are clonally related, or so on, because we stratify them based on the prognosis. These tumors will behave well, so these tumors we will call it like independent primary. And the FIGO staging 2023 for endometrial cancer assigned a stage 1A3 for these cases. The low-grade endometrioid carcinoma limited to the uterus and the ovary with all these features, and in addition that the ovarian tumor is unilateral limited to the ovary without capsular invasion or rupture. So it is equivalent to BT1A. So if any of these criteria is destructed or is lost, any one of these criteria is lost, we will say that this tumor is metastatic from the endometrium, and this is a stage 3A. If all these features is present, we will state that this is a stage 1A3, and these tumors, it's recommended to call it not synchronous, to call it coexistent endometrioid carcinoma in the ovary and the endometrium, and it's a stage 1A3, and explain to the clinician that this group will behave good prognosis and will have conservative management. This stratification is now, there's a work done on this stratification that we use. This study, large study, included the molecular classification with the pathological features that already defined to call it behave like independent primary or metastatic. So when we add the molecular classification, the low risk feature NSMB profile, ER strong positive and the polymutant to the endometrial tumor, and the intermediate high risk category, the MMR deficient, P53 abnormal, non-specific molecular profile, ER negative. So they add, this is a low risk and this is intermediate high risk. When we add these molecular features into the criteria that already assigned for these tumors, we may expand the cases that will have conservative management and will have favorable prognosis. So if I have a tumor, endometrioid carcinoma in the ovary, in the endometrium, with bilateral ovarian involvement, but the ovarian capsule is intact. Okay, and this tumor is non-specific molecular profile and a strong ER positive. According to this, we may يعني we may have conservative management for these as these will have good prognosis. So this study integrate the molecular classification with the criteria that already assigned for this tumor to say it's synchronous or metastatic, and this result in more expansion of the cases that can treat it conservatively, about 49% versus 20%. And there is a trial in Canada, I think, about this now. They trying this in a clinical trial, the compare trial, to investigate this. So this is the new things that will be done. But until if we don't have molecular classification, we stick to the FIGO staging criteria. These criteria, if present, these tumors will have good prognosis and no adjuvant treatment. If this criteria is not present, we considered it's metastatic from the endometrium to the ovary. And the ESTRO-ESP guidelines have some difference from the previous study in that they include the MMR deficient group in the low risk category. But we'll see these studies will be more validated in clinical trials after that. Regarding clear cell tumors, also there is benign, borderline, and malignant, but the benign and borderline is extremely rare. The malignant, we encounter it. The mean age is 56 years, arise in endometriosis in 50 to 70% of cases, may be associated with Lynch syndrome, may be associated with paraneoplastic hypercalcemia and venous thromboembolism, typically unilateral, as a solid or solid cystic or mainly cystic when in background of endometriotic cyst, may arise on top of clear cell borderline tumor and adenofibroma. So here is an example of one cases of a clear cell carcinoma that shows cystic lesion. This is an endometriotic cyst in the background with these papillary structures that reveal tubulocystic papillary proliferation lined by clear cells exhibiting high degree of cytologic atypia. So this is a clear cell carcinoma. The diagnosis of clear cell carcinoma based on the typical architectural pattern and the nuclear features with the presence of clearing. The presence of clear cells only is not diagnostic for it. You may see in our report endometrioid carcinoma with clearing. So clearing can occur in some other tumors, and this is not equivalent to clear cell carcinoma. So clear cell carcinoma can be clear, can have clear cytoplasm, can have eosinophilic. There are other features to diagnose it as clear cell carcinoma. The immunoprofile is very helpful. It's generally PAX8 positive, ER negative, P53 wild type, and WT1 negative. Napsin A and HNF1 beta is often positive. We have napsin A, we depended largely in clear cell carcinoma. So this is a clear cell carcinoma that shows this coarse granular brownish staining. This is napsin. And here is another case show more diffuse stain. So the recommendations for endometrioid and the clear cell carcinoma is to do a molecular classification for endometrioid carcinoma to stratify the ovarian endometrial carcinoma can be done. Recommendation 2 is the molecular marker are not recommended for prognostication of ovarian clear cell carcinoma. And recommendation 3, we must do the DNA MMR, IHC, or MSI testing recommended in ovarian endometrioid and the clear cell carcinoma to identify the Lynch syndrome. The mixed carcinoma was removed from the previous classification and then reintroduced in WHO 2020. It's a very rare, less than 1% of cases. Two component morphologically and IHC separate from each other. I have two tumors by morphology and by IHC, they are different. In previous decades, this was common to see mixed carcinoma, but now the definition is short and rarely to see mixed carcinoma. When I see mixed carcinoma, this is most common, usually in the setting of endometriosis. We can see endometrioid carcinoma mixed with clear cell carcinoma with mesonephric-like carcinoma, like this. So this is algorithm of the immunohistochemistry in any case of suspected ovarian cancer. So if we have adenocarcinoma, CK7 positive, CK20 positive. If we have PAX8 diffuse and strong, this is highly suggested that this is a gynae malignancy. If it's negative, it's not gynae malignancy, except in ovarian mucinous carcinoma. As we said, they can be negative. If the tumor is positive for WT1 strong and diffuse, this is ovarian serous carcinoma that can be low grade or high grade based on the P53 wild type or mutant pattern. If it's negative, it could be endometrial serous carcinoma or it could be clear cell carcinoma if NAPSIN positive, or ER and BR positive if ER and BR positive endometrioid carcinoma. A few slides about the secondary carcinomas to the ovary, the metastatic. So the mets in the ovary may mimic primary ovarian lesions and may mimic also the borderline and the benign entities, not only the malignant entities. So the malignant carcinoma coming to the ovary can be misinterpreted as a mucinous cystadenoma, mucinous borderline, mucinous carcinoma, endometrioid carcinoma. Generally, the mucinous and the endometrioid are the most common times to be most misconfused with metastasis. The site of mets can be from the appendix, from the colon, the stomach, the pancreas, gallbladder, cervix, small intestine, breast, and lung. The features that favoring ovarian metastasis, usually the bilaterality, and these features are very important because they help us really in diagnosis. The bilaterality of the lesion with the small size, the extensive intra-abdominal spread in a mucinous tumor. We say that mucinous carcinoma is usually stage 1. So when we have extensive intra-abdominal spread in mucinous tumor, this is not likely to be primary ovarian. The pseudomyxoma peritonei, the ovarian surface involvement with the hilum of the ovary involvement, the nodular growth in the ovary. Under the microscope, if there is an infiltrative pattern of invasion with desmoplastic stroma, as most ovarian tumor tend to be expansile rather than infiltrative. If there is extensive LVI, the lymphovascular emboli, also not common to be extensive in primary ovarian carcinoma. The extensive signet ring morphology, this is more with metastatic. Colloid carcinoma pattern means there is a lot of mucin. A small invasive gland with plain cytology, this also features microscopic, raise the possibility of mets. The role of IHC markers, it has role in differential diagnosis, but not used in correlation. In these cases, we must correlate the clinical radiology, gross and microscopic feature. This is very important to reach the correct diagnosis because it can be difficult to diagnose solely on the microscopic features or the IHC. And here's some of the IHC markers that can help in differential diagnosis. So if I'm thinking of the lower GI, the SAP2 is very helpful in differential diagnosis from the primary gynecological cancer. The upper GI is not have specific markers helpful. The pancreaticobiliary, we can have the SMAD4 lost in about 50% of pancreaticobiliary carcinoma, can help in differential. In the cervix, we can, if suspected extension from the cervical carcinoma, we can use the B16 and the HPV in situ hybridization. The breast, we can use the GATA3, mammoglobin, and GCDF15. The lung, we can use TTF1 and NAPSA. Thank you.
ثانك يو دكتورة أماني. أنا مش عارف أنا صوتي طالع ولا لأ.
طالع واضح.
طالع بس أنا على الطريق بس. ثانك يو ريلي، كانت حاجة very very informative. أنا مش عارف بقى لو هل في حد من الأودينس، في ناس رافعين إيديهم ولا مفيش حد رافع إيده. هو أنا عندي كويستشن، أنت قلت لي عارفة أنا هسأل على إيه يعني. لو ممكن بس نوضح حتة البوردر لاين with micro invasion أو border line with micro invasive carcinoma.
تمام. هو البوردر لاين وذ مايكرو انفيجن، هما الديفرنس بينهم بين المايكرو انفيجن والمايكرو انفيزيف كارسينوما هما الاثنين كده كده اقل من 5 مللي، بس الديفرنس بينهم ديفرنس في الهيستولوجي. المايكرو انفيجن ده بيبقى سمول كلاسترز كده اوف ايزينوفيليك سيلز. الايزينوفيليك سيلز دي هاديه، بيتقال عليها سينيسن سيلز، يعني نو بروليفريتنج. المايكرو انفيزيف كارسينوما دي بتبقى حته كلاسيك كارسينوما بس صغيره اقل من 5 مللي.
ماشي، دي بقى
فالبيهيفير بينهم
بتتكتب
البيهيفير
دي
بينهم
مكتوبة في
مختلف.
بتكلم على طريقه كتابتها في الريبورت. دي بتتكتب بوردر لاين وذ مايكرو انفيسيف، بوردر لاين وذ مايكرو انفيجن، لكن هي بتتكتب بوردر لاين وذ مايكرو انفيسيف كارسينوما، ولا انا بتكلم
ايوه
غلط؟
بالظبط. لا بالظبط تمام كده. فهي عشان كونفيوزنج شويه، فهم في الدبليو اتش او الجديد هيشيلوا اصلا كلمه مايكرو انفيجن ومايكرو انفيسيف كارسينوما، وهيسيبونا عادي نقول السيريس بوردر لاين اللي هو فيه مايكرو انفيجن هنقوله عادي سيريس بوردر لاين تيومر، واللي فيه مايكرو انفيسيف كارسينوما هنقولها عادي انها كارسينوما بس
هايلوكلي
صغيره.
سيريس.
هنقول الايه سايز بتاعها، نوضح ان هي صغيره وطالعه ان توب اوف بوردر لاين تيومر عشان الكونفيوجن ما بين الاثنين.
دي يتقال عليها لو جريد سيريس ولا يتقال عليها ايه في الاخر؟
لو جريد سيرس كارسينوما. ايوه لو جريد سيرس كارسينوما. ما هي مايكرو انفيزيف لو جريد سيرس كارسينوما، يعني هي لو جريد سيرس كارسينوما بس صغيره اقل من 5 مللي. فهم بقى هيشيلوا حته 5 مللي بقى والحته دي عشان بتلخبط، وهيخلوها ان احنا نقولها سمول لو جريد سيرس كارسينوما، ونحدد الايه السايز بتاعها ان باك جراوند اوف سيرس بوردر لاين تيومر عشان الكونفيوجن يعني.
تمام. دكتور احمد سيودان بيقولها very informative and to the point. لو في حد تاني عنده اي اسئله يبعتها على الكيو اند اي. انا معلش عندي سؤال تاني في موضوع الميوسينس برضو، عشان في حته كده كانت تاهت مني شويه. السؤال اهو: كان بوردر لاين سيرس كارسينوما هاز نون انفيسيف او mental deposits؟ يا اكيد بس ردي انت احسن. ده
السؤال ايه
سؤال
معلش؟
كان بوردر لاين سيرس كارسينوما هاز نون انفيسيف او mental deposits؟
يس، سيروس بوردر لاين تيومر ممكن يبقى فيه اكسترا اوفيريان انفولمنت بيعمل امبلانت عادي في الاومنتم، ممكن تبقى نون انفيزيف، او في سمول برسنتج اوف كيسز ممكن تبقى انفيزيف فيتقال عليها لو جريد سيروس كارسينوم. انما الميوسينس ما بيعملش امبلانتس. تمام، السيروس بس والسيرو ميوسينس.
تمام، انا خدت بالي من
دكتور
الحته
دكتور
دي
طارق
بس.
رفع ايده يا دكتور خالد.
دكتور طارق.
اه
دكتور
رفع
طارق
ايده.
كاتب: in case of serous borderline ovarian and low grade serous carcinoma in the omentum considered as a malignancy.
ثواني اشوف السؤال بس انا ما خدتش بالي. in case of a serous borderline ovarian and low grade serous carcinoma لو الاوفاريان تيومر borderline تيومر واللو جريد سيرس كارسينوما في الاومنتم، ايوه دي بتبقى لو جريد سيرس كارسينوما ستيج 3. بس احنا واحنا في يعني في الكتابه عادي بنكتب ان الاوفري borderline والاومنتم فيه لو جريد سيرس كارسينوما، بس ده considered malignant stage 3 لو جريد سيرس كارسينوما. هي المشكله بتحصل لما يحصل العكس بقى، لما يحصل لو جريد سيرس كارسينوما في الاوفري والاومنتم فيه نون انفيزيف امبلانتس مش شكله فرانك انفيجن، فالحالات دي بتبقى صعبة شوية في الريبورتنج. هل الموضوع ده له سيجنيفيكانس ولا هل نقولها ستيج 3 لو جريد سيراس كارسينوما وخلاص؟ بس دي رير كيسز يعني بتتكتب بشكل معين ديسكريبتيف وبيبقى فيه نقاش مع الكلينيشنز وكيس باي كيس في المانجمنت يعني. انما لو انا عندي بوردر لاين تيومر في الاوفري وفي لو جريد سيراس كارسينوما في الاومنتم ده مالجنا، دي خلاص لو جريد سيراس كارسينوما ستيج 3.
تمام تمام، واضح. انا السؤال اللي كنت بساله بقى كان في حته كده كنت بتقولي على الميوسينس اوفيريان والسودوميكزوما. يعني مش اللي فهمته ان ما فيش سودوميكزوما تبقى طالعه من اوفري، لكن تبقى دايما طالعه من ابندكس، ولا انا فهمت غلط؟
اه، السودوميكزوما ما بتطلعش من الاوفري الا في سيتويشن نادر قوي، نادر الحدوث، ان ده بيبقى ميوسينس تيومر طالع on top of تيراتوما. لان
تيراتوما.
هو
اه.
ده بيبقى رير سيتويشن ممكن تحصل، وده الوحيد اللي ممكن يعمل سودوميكزوما في حالة الاوفري. غير كده هي بتبقى طالعة من الابندكس، في نسب قليلة جدا بقى اقل من 5% ممكن تطلع في اماكن تانية في الجي اي يعني مش من الابندكس، بس هو موست commonly من الابندكس.
ماشي، انا بسال لان دايما في الديسيمينيتد ديزيز في السودوميكزوما لازم بتشيل الاوفرز واليوترس والاومنتم، لازم يعني كل ده لازم بيتشال.
مم. ما هم غالبا بيبقوا involved يعني، هما غالبا بيبقوا
اه، ما ده بيبقى
انفولفد
برضه
وبيتشالوا،
وده
بس
بيبقى
قصدي
برضه.
هي بتبقى بتعمل كونفيوجن شويه في طريقه الريبورتنج بتاعهم، لان ساعات بيتقال ان اللي في الاوفري ده ميوسينس بوردر لاين تيومر، ويتقال ان اللي في الاومنتم ده سودوميكزوما، فبتبقى ساعات مش مفهومه ازاي ان ده ميوسينس بوردر لاين وكده. فهو لا، هي الكونديشن كلها ده انفولفمنت مثلا بلو جريد ابندسيال ميوسينس نيوبلازم اللي في الاومنتم واللي في الاوفري ولو في ديبوزيتس في حته تانية.
تمام تمام. طيب، في اي اوبن كويشنز تاني؟ في حد بعت سؤال تاني؟ مش عارف تعرف تقري يا دكتوره اماني من عندك؟ دكتور احمد
بوردر
سويدان
لاين
بعت
سيرو
سؤال.
ميوسينس have high risk of recurrence. Dr. Basil, what's the treatment in young patients? Adenexectomy or cystectomy.
طيب يعني again borderline is a separate entity. We are going to have special lecture for borderline. Treatment in borderline is usually conservative as much as you can. We are now going to have new ESGO guidelines about borderline. It will be finalized next year, inshallah. It will start this year and finalized next year. So a whole ESGO guidelines alone about borderline. But up to my يعني experience now, borderline treatment usually go conservative. Old school بتاع doing a direxectomy, if it is unilateral, maybe omitted me, you can do cystectomy only. It is not a mandatory to do يعني oophorectomy, even if it is unilateral. If it is bilateral, for sure you are more conservative, and you don't have to remove the uterus. You don't have to do completion surgery when she completes the family, or when she is postmenopausal. So borderline we are removing, even it is not in the ESGO guidelines for invasive ovarian cancer. There is no nothing at all about borderline. Borderline is not cancer, and it is another, it's a tumor, more or less, with a very good prognosis, and it will be a special entity outside of invasive carcinoma. يعني try يا أحمد to be as conservative as you can. Don't be afraid of this, and wait for the ESGO guidelines about borderline tumors. So finally, to conclude, thank you, Amany, so much. Thank you, Dr. Khaled Gaballa. Just a final statement that pathology is a very, very mandatory cornerstone in gynae oncology, in all oncology, and all oncology management and treatment. And pathology is just, it is knowledge, it is sectioning, it is seeing things very accurately. So you must have a trusted gynae pathologist. You must have, or at least have the double check, two eyes to see it, two eyes to discuss together. Having someone like Amany is يعني very, very important step to be a good gynecologist, or to have a competent gynecology team. But again, don't take all pathology reports as يعني granted that they are correct, especially if you have something unusual. You have to revise, you have to read the pathology report, you have to learn how to read the pathology report, how to know if this pathologist is competent enough or not, and don't ever hesitate to have another opinion and to have revision of your pathology. This is very important. بدون زعل يا امان، يعني بعدك انا ما بشوفش حد بعدك خلاص، بس يعني it is very important to have second opinion في الباثولوجي.
I agree.
Yes. اعتقد دكتور خالد you want to conclude and close.
Okay, Dr. Basil, يعني thank you for your share, and thanks a lot for Dr. Amany. I think next week Dr. Amany will complete, I think, germ cell and six-cord stromal tumors. Yes.
Yes, it will be a small lecture, just enumeration and to know the markers of the germ cell and six-cord tumors, with few words about intraoperative consultation in the GYN in ovarian tumors. So it will be a small lecture, not a long lecture like this, inshallah.
It will be a short lecture.
Oh,
Your lectures are never small, Amany. Just a short, but usually precious and big lectures.
Thank you.
okay, see you all next week. See you.
Okay, bye bye.
Okay, bye.